Good afternoon, everyone. This is Matt Bancroft, TASC, and welcome to the almost said November, might as well be October TASC 90 on critical access hospital forecast, financial forecast post COVID-19. As you know, that's kind of where we're heading. We have some information on the screen there, as you can see. And I am going to inform you that we are changing the order of operations today. And with us this afternoon, we have Ralph Llewellyn from Eide Bailly, who's going to present on this topic and then be open to a couple of questions. Due to some previous time constraints, Ralph will go first, and then we will do program updates towards the end of our time together. If you have any questions, feel free to raise your hand. Ask any questions that you may have in the chat box. Along the way, we will also post links to some important documents that you may find tie into this topic well, or that you may reference later on in the conversation or in your day-to-day operations. So at this time, I would like to introduce you to Ralph with Eide Bailly, and he's going to start sharing his screen, and he will take it from here. Patricia, if you wouldn't mind, as he gets started launching the polling, and we would appreciate it if you would take just a second as that jumps up to answer those quick few questions.
All right, is it over to me now?
Yes, sir, it is.
All right, well, thank you so very, very much. Just want to confirm that you can see my screen.
We certainly can.
Perfect. All right. Well, thank you so much. I really appreciate the opportunity to get to visit with this group today and talk about a topic that I just think is really forefront and really needs a lot of attention in the organizations, and that's really looking at financials and the readiness of organizations as we look at moving forward through the end of COVID, hopefully at some point in time. And back to some sort of whatever we want to call it, normal or the new normal or the world that we're going to have going forward. So let's see here. There we go. Just a little bit about myself. I'm Ralph Llewellyn, and I'm the partner in charge of critical access hospitals for Eide Bailly. By background, I'm a former hospital CFO, and that was about 5 years back in the early 90s. Since then, I've been spending my time with the opportunity to get to work with rural providers throughout the country. I'm not sure how many hospitals that is now, but it sure is a lot. It's been a great opportunity to help them with improving, hopefully, their financial performance and where they're at. So a little bit about just setting the stage. So I think that's really important. When we think about where things were at pre-COVID, there were challenges already before COVID came along. It's not like the challenges are new. They're different today, but there definitely were challenges there. If we go back and look, there was already a 2020 report that said that 27% of the critical access hospitals in the country were at mid-high to high financial distress. And so when COVID came along, I remember in March of 2020, I was getting a lot of calls from entities that were not counting cash in days. It was more in minutes. It was, how am I going to continue to pay payroll and make all these other needs when I don't have patients, but the ones I have are really sick, and all of those those pieces. And we were promised all of a sudden real quickly that we're going to get a lot of funding coming in, a lot of it coming through the government and at speeds that we'd never seen before. And many of us questioning, could it really happen that fast? And in reality, they did get money really fast. And so we had these big infusions of cash, and these infusions really created kind of a temporary relief, or took the pressure off. I actually had some providers that called me and said they went from having almost no money to having more cash than they ever dreamed of having in their facility ever, overnight. And unfortunately, what we're seeing now is those funds have been expended, or the spend rate on those funds is starting to wind down as far as what's available and what's left. And the long-term realities are starting to set in. Some of us have called that the post-COVID hangover. We're feeling good from all the funds that came in. Now that they're gone, the headaches coming back, the challenge, and all of that. And the challenges are all over the place. We hear about turnover and And I want to make sure people know that it's not just turnover of one area. I mean, it's C-suite turnover. You know, what I watch a lot is a lot of Becker's and a couple of other reports that come out that show changes in movement in the C-suite, CEOs, CFOs, CMOs, CNOs, all of those huge openings. And when you find out who's looking for replacements, we're finding that the individuals are taking a much longer time to find a replacement. Sometimes it's a lack of applicants at all. Sometimes it's just a lack of qualified applicants, but there's this huge void there at that level. And then we've all heard about, you know, the clinical pieces, you know, but it's not just the clinical staff, you know, the nurses and things like that, lab, pharmacy and all that. It's even the non-clinical. I'm at a conference right now that I'm out here talking at, and, you know, they're talking about people in the business office. They can't find people for the business office. Functions that, you know, in the past they may have struggled to get the quality they wanted, but they could at least get applicants. Now they're not even getting applicants. And then we got increases in costs. And so increase in costs are coming in multiple different directions. You know, it's an increased cost of labor. There is the, you know, and that's either through contract labor or, you know, whatever else we have as far as employment labor and what we have to pay people and reward them to stay with us. There's the cost of supplies, the changes and increases there. Construction, I don't know if I've ever seen this much of a growth in expended expenses as far as construction goes. And so a lot of people are trying to build things that they were trying to do before COVID. They're finding the construction costs are way out there. And so you look at what's happened in inflation, you know, we've probably been very blessed for many, many, many years prior to COVID with lower inflation rates, you know, 2.3% in 2019, 1.4 in 2020, and then you start looking at 2021, it's up to 7%. Year to date, you know, we're at 8.3%. Those numbers are just growing, and those are taxing the financial ability of these rural providers. And then at the same time, if the cost wasn't bad enough, you know, there's lower or changing volumes. You know, either they have totally a different mix of services they're doing. So maybe they're keeping the same total volume, but the mix has changed. So they're having to rearrange that. Or in some situations, they're still just really struggling to get the volumes back. And so, and some people I think have gotten to the point where they don't think they're ever going to get back to the levels that they had at one point. On top of that, excuse me, we see revenue cycle pressures. We see a big increase in the amount of denials and pushback from payers, and just overall, just more uncertainty going on within the organization. And so with that, you know, what we need to really start looking at is, you know, what are the things in the forecast, the things that people need to start looking at doing in their organizations to try to drive some bottom line, some improvement, and get some things going. So let's start with revenue cycle pressures. The revenue cycle pressures, you know, when I look at revenue cycle pressures, the first piece that I'm looking at is trying to make sure that we capture, you know, the collections for what we've already done. You know, I've already talked about expenses going up and all that, and we got to worry about expenses. We've got to worry about the number of staff we have. The first thing we need to make sure that we're doing is that we're actually capturing the revenue for the services that have been rendered. And revenue cycle is a tough topic. You hear about it at all the various conferences. And while you hear about it, everybody's still struggling with it. So it starts with the charge master. In the charge master, it's two components. It's the charge master and it's the charge capture. The charge master itself, maintaining it is more the compliance and the efficiency of it. Compliance meaning that you've got the right CPT codes and HCPCS codes and other, you know, codes that identify what the services were. At the same time, making sure that you're only billing for those things that you can actually get paid for, and not billing for those things that are just make work exercises. So it kind of gets into the efficiency side of it. The charge capture side is more of how do they utilize it. And what I mean by that is we've ran into situations where people have a perfect charge master, or as close to a perfect charge master as you can find. The problem or the challenge that we have is that the people haven't been taught and given the proper tools to understand how to actually capture the charges. So when they do something, they don't know exactly what they should capture, what they could capture, and so there's these breakdowns. And so because of that, I would say when we look at reviews, probably 25 to 30% of all outpatient claims that go out have an error in it. And oftentimes these are errors that if somebody would have captured something, reported something correctly, there may have been an additional dollar that could have been collected along with that claim. So that's the first piece. The other part, pricing. Pricing transparency is a big deal out there. What we're looking at in pricing is not just the reporting of the transparency that we have to do, but small rural providers typically are the ones that tend to fall behind in keeping their pricing up. They've done small to minimal increases in the past. The larger entities have increased their prices at much greater rates. And so we have organizations that aren't actually capturing the revenue, the gross revenue, as well as the cash behind it for the services they've rendered. They're spending the same amount for staff, supplies are costing them the same, if not more. Their pricing model is bad. And so it's making sure it's high enough, not too high, because we don't want to be, promoting gouging or anything like that. And then it's just the methodology of how do they keep it up to date. Big systems, large systems have all kinds of tools and extra staff and things like that that can help with pricing. Oftentimes in the small rural provider, it's the CFO, they may have a revenue cycle person, but it's just one of many tasks that doesn't get the attention it really needs. Another part in the rev cycle pressures we see is just accountability. The business office in most of the facilities I deal with are understaffed for the processes they have. And what I mean by that is there's probably the right number of staff for the work they're doing as a facility. The problem is that they're not making people do things right on the front end. The people in the business office are correcting them. They're correcting claims, they're correcting demographics, they're correcting documentation, they're correcting all these things. And oftentimes leadership won't hold those originating departments accountable and forcing them to do it right the first time. They end up having to help fix it later. And, so there's a lot of time spent on that fix it process. And with that is usually a lot of lost opportunity from a revenue as well as lost time. Denials management. This has actually been a piece that, it's been around for a long time, but it's really grown a lot in this last year. And, we're seeing payers that are denying more and more services and challenging. And so facilities are oftentimes able to, after the fact, get these overridden, but there's a lot of effort and a lot of work going around like that. I mean, I just saw a news clip yesterday, a facility in Oklahoma that dropped one of the, or I think they may have dropped all of their Medicare Advantage contracts and said, we're not on contract anymore because we're tired of all of the denials. About 80% of their claims were being denied that were going to commercials, whereas in the rest of the organization, they were probably at about a 20%. They just said, we can't put up with that. We can't live with it. We don't have the staff to fix it. And so there's a lot of things going on. So larger write-offs, larger volume of individuals. And so people spend a lot of time, a lot of effort fixing versus trying to figure out how to prevent it. Right now it's, if you are trying to prevent it, a lot of times it's manual. There are some data analytic tools out there now that we're seeing people utilize to help kind of try to drive that improvement. So tools, what kind of tools, if you're working with providers, if they're struggling in the rev cycle, a couple of tools and things that they could be looking at. I always like to promote tools that the centers put together. So I did put a link there to Revenue Cycle Management Best Practices Guide. It's got some good pieces to it. Sometimes there's going to be people that maybe need a little bit more nuts and bolts and specifics on it. Very, very good document though. And so that's a great starting spot if you haven't looked at that or provided that to an entity. Charge master pricing reviews. We hear about those over the years, and many organizations do a pretty good job. They should probably have a review in this area probably every 3 years if they're done right. Some organizations will promote you should have to have a full review every year. I think that's overkill. If you get too far beyond 3 years, then you start to have problems just because of so many rule changes and things like that. The other part is revenue cycle assessments. This is really looking at the process flows. This is focusing on that whole piece where I talked about putting accountability into the process, where you're making sure that things are being done right the first time. The processes are set up for that. There's reporting if they're not. Trying to increase the throughput and decrease the effort it takes to get the same or hopefully even more dollars through the door. So definitely a lot of things to keep in mind in that whole area of revenue cycle. The next one, and I have a session after this, a roundtable I'm hosting, and I know that it's going to be about workforce. We're getting more and more questions on workforce all the time, and absolutely I get it. Everyone's looking for this easy answer, and unfortunately, I don't believe in the market today that there just is an easy solution. It's not about just paying people more. It's about trying to attract them to stay even in the industry sometimes. But how do you get them to come to your entity? And so again, it's not all about compensation. What I would say is that, when we look at those that seem to be doing better than others, there are probably a few factors that seem to drive that. One is organizational culture. I think all of us can tell when we're working with a facility or in a facility, you can tell the difference between culture from one to the next. Some have amazing cultures and some are much more of a challenge. Doesn't mean that they're a total wreck, but there's just more challenges there. Some are close to that wreck. You really need to, if somebody's looking at their workforce and they're struggling, I think they need to start, looking at least a little bit with some self-reflection as to, what are they trying to sell? What are they trying to push into the market? And that starts with organizational culture, and then leads into the next piece, which is leadership. How strong is that leadership? How good is it to work for that leadership? How trusted is it? Do they make it feel good to be part of that organization? And then I think the other part, I said it's not all about compensation, but we're seeing people working to become more creative with benefits. What can they do to provide a benefit or something that's different than everybody else? Some of these may be a little bit more expensive. Some of them are not expensive at all. Some of them are just, how they handle daycare. I mean, that's maybe a more expensive one, but I've seen some where they've actually set up their own daycares to help staff be able to get daycare, because that's a reason why some people are staying away from the market or going from one organization to the next, just because of the availability of daycare. We're seeing a little bit different things going on in the area of tuition reimbursement, not just for those new people that are starting to go to school now, but even some on loan repayment. There's a lot of taxable implications you got to watch there and stuff, but it's trying to figure out how do you differentiate yourself in that market. As far as resources out there, there is a resource out there on the center website. I've added that there, so I recommend you start there. The other thing that we're starting to see more and more organizations doing is reaching out to human resource consultants, looking at having them help look at what they're selling when they're trying to sell their workplace and things like that. 5 years ago, I don't think I would have said that there was a lot of focus on people using HR consultants for that purpose. I mean, they were looking at, their overall benefit plans and things like that. But this seems to be like an area that's really creeping up, getting a little bit more engagement, more involvement, and more interest. So don't be surprised if people have a need for that, or if you start to see more and more consultants around that. I've been seeing a little bit more of that at even some of the conferences I've been at, where there is a little bit more of that human element that they're starting to look at. Again, what are you trying to sell in the market? The strategic plan, and in this, this is kind of building up to, how do we start trying to make sure that we're pushing out to the market what we need to as an organization. COVID-19 changed everything. I had some facilities that had strategic plans that were done in the late 2019, early 2020. And, I told them shortly after COVID hit is that their strategic plan was null. They had to start all over again. Technology changed. Some of us did a little bit of telehealth, prior to COVID. Now we have many that have fully engaged and are looking to expand it, and the e-visits, the virtual visits. We also have things that we're looking at now as an organization that, affect patient flow. Before COVID, I don't think I had many conversations where people were calling me and saying, we're trying to figure out ways to how we better segregate our ill patients from our chronic patients. So I had people who were coming in with COVID. How do I keep them away from people that are coming in for just chronic follow-ups and things like that? And they're looking at how do I do that in the future? I don't think I can go back to what I had done. And what we've seen there is that, we've got a lot of critical access hospitals that struggle for space. And because they've struggled for space for decades, they've become extremely creative and efficient on using the space they have. Oftentimes having more than one service shared in a space. Maybe it's different times of the day. Maybe they can do both of them in the same space at the same time. A variety of different things. Well, with COVID, that changed what people were looking at, and now they're, oftentimes saying, we have to make sure that we don't commingle these types of things, because when something like COVID happens, we're not prepared, we're not able to react. And so all of this really kind of leads us back to, the strategic plan and, what's going on. And really you got to look at, how healthy is the strategic plan. And, strategic plans aren't new. I had classes on that when I was in college in the 80s. And people were talking about it well before that. But it's how in depth is the strategic plan. So, a starting point with maybe providers that are struggling and trying to figure out what they're going to do next and how they're going to live in this future world is to start talking to them about, how healthy is their strategic plan? Is it current? And again, current is probably not something that happened, pre-COVID or just as COVID was taken out. How engaged? How engaged is the organization in their strategic plan? Is there monthly reporting? Do they actually use it and live by it and report out to it most often, like at a monthly board meeting to talk about what's going on? Or is this an organization that dusts off their strategic plan every 1 to 3 years, creates a new one, sticks it back on the shelves, and then just dusts it off again in another 1 to 3 years? Next, is, how complete is it? And I'll talk a little bit about what I mean by complete. I see some people doing very superficial strategic plans. I see some facilities doing immensely deep and thoughtful processes. So there's lots of things going on, in that realm. And is it built for the future? What I mean by that is, does it take into account what's changed in the industry, and not rather than, what's going on today? And, really you want to make sure at the end of the day that you're building what you're going to need at the time that you get to the point of implementing it, not building something as far as a plan that takes care of the needs of today, because today's needs will be past us by the time we get something implemented. So types of things that, we really thinking as you're working with providers and looking forward, things that should be addressed in a solid, robust strategic plan. And by the way, robust doesn't have to be expensive. Robust may take more time, which has got some more expense, but we're not talking, it has to be inordinately expensive. It just has to be the appropriate investment. And so community health needs assessment. I've had conversations with many folks over the years about, what we see as community health needs assessments. Some organizations basically check a box. They did the very, very bare minimum of what they needed to do in the community health needs assessment, while others are looking at it as an opportunity to really dig and find out what's going on in the community, finding out, why people don't use them when they don't use them. Really, use that time and effort and that invasion of people's time to really get good information. And so while there's a huge variety of types of community health needs assessments we see, the ones that seem to really set the facility up for planning and using it as a fruitful document going forward are going to be those ones that dig deeper than what the IRS requires, really digging into what should you want to know. Other things, patient preferences. You know, what I like to look at there and what we think about that is more about, you know, what's the market share? You know, pulling market share data, a lot of times people use just kind of, well, we feel it's this way. It's more of a gut feel. It's strategic planning. This is really getting data and saying, okay, based on maybe Medicare data, this is how much of the Medicare inpatients in our zip code areas came to us versus where, you know, other places. And, you know, when they did go somewhere else, where did they go? Kind of really understanding the guts of what's happening and realizing that, you know, there may be reasons because it's services we don't offer, but what if there's services that we are offering and they're going somewhere else? Trying to dig into what's going on with that. A lot more data, and data is, you know, things like, you know, population trends, you know, trends male and female, you know, any type of trend that you should want to know if you're putting together a future looking plan. Helps you understand, you know, what services you may want to add or not add. You know, one that we look at oftentimes is the, you know, the population and the trend of birthing age moms or birthing age women, and trying to figure out, you know, what will that do maybe with the OB needs, and doing that based off of data becomes part of the strategic plan. You know, looks at technology, other industry trends. There's data out there that says these are the types of services or medical areas that, you know, it's anticipated a specific area is going to grow in, or those that are going to retract. You know, so as you're looking at a strategic plan, your plan is to focus on building things that are going to grow, and maybe just, you know, still maintain things that are going to be stagnant, but not investing in things that are known that they're going to go away. And so trying to really lay that all out, because at the end of the day, with all this data and all this information, you know, what you want to do is get a strategic plan that's getting you, you know, where you need to be in the future. I like, you know, Gretzky's quote, you know, when they asked him why he scored so much, and he said, you know, you skate to where the puck is going to be, not where it's been. And your strategic plan should be basically you skating to where the future is going to be, not where it is today or where it's going to be, it's been in the past. It's really laying that out. And so with all the changes that are going on, and kind of brings us to another quote that's out there, you know, from Marshall Goldsmith, you know, what got you here won't get you there. Things need to look different. Our organizations need to look different. Our patients look different. They have different expectations. They're accessing healthcare different. You know, there's so many different things going on. That's really where people need to be focusing and working on, as they're preparing themselves to be ready for the future. We talk a lot about, you know, what's the future of healthcare look like? You know, a new definition of access. You know, some people are going to want care to be available almost 24/7. I don't believe they actually need it 24/7, but maybe it's not. Maybe it's beyond 8 to 5 now. Virtual healthcare, it's here to stay. You know, how are we playing in that? Population health. Population health was here before. The population health has huge opportunities to increase the number of services that you're doing at the lower level of complexity. A lot of preventive, monitoring, things like that there that help us identify things earlier, keep people healthier. Health apps, you know, we've all got them, as well as we've got wearables, you know, things like that there. Appointment booking is almost going all online now. You know, we're seeing that even in our small rural settings where they're automating as much of their appointment making. Some of it's just because they don't have staff, can't find staff. And then the patient portal. So we just really need to have organizations that are looking at how do they redirect or rethink their future as to how they're going to deliver things out into the healthcare market. You know, resource management, you know, this is kind of the cost side of things. You know, I talked a lot about how do you try to drive volumes and things like that. Good strategic plans, you know, collect for all the work you've been doing, But you do get to a point where you got to look at the expense side also, because there's more than just the revenue that can take you there. You know, because of all the changes we've talked about already, we've got to find ways to be more efficient. So, you know, when we had the PHE, we know that some entities had to get things done with less people because they couldn't find them. And so they changed processes, and they, you know, they figured ways to get things done, you know, in another model, another process, another way. And as painful as that was, I think it's also been a really good opportunity for us to learn about what we can do. Because how many things are we doing today that we would have never thought of doing before if COVID wouldn't have been the piece that pushed us in that direction? So of the changes that we've had, rather than being an organization that's saying, oh, as we come out of COVID, I can't wait until we go back to the way we used to be, it's more of this, you know, what did we change that could be sustainable in the future? And we should be thinking about that, not adding that person back because we found we didn't need it. We could function. There's a different way to get there, either through technology, through processes, or something else. And so the focus here isn't just reducing staff, but it's what happened to the process. You know, process is a huge thing. I think about working with one clinic. First 6 months of the year, they had one person month, you know, 1 month of coverage with the provider less than what they did the year before. So, you know, let's say they have 6 providers, they had 6 in each month, but 1 month they only had 5. That was how they were a little less than what they had been running. So they're down 1 provider for a month out of the 6 months, and their visits were up 20%. And their providers were happier. Their staff were happier. That wasn't because people were working harder. It's because people had done some things to the process. And they, you know, so they fixed the process to make people able to get more things done with less. They also had to focus on technology, using, you know, data, as well as, you know, artificial intelligence, using systems, all of that. And so there is a big push to be jumping into this arena a little bit more. But the focus, I think, is really got to be, how am I going to change my processes and utilize technology so that I can improve? Not how do I just say you're going to do with less, change the staffing levels and think that's just going to happen. That doesn't work. And so, you know, what types of tools? There's not a lot of tools I could find online that are just sitting out there. You know, benchmark analysis is a good one. You know, this is looking at how many hours per statistics, like hours per test by department, hours per patient day on the med-surg floor, things like that. Now, these aren't absolute perfect science, but they can help people understand, you know, how maybe they are doing compared to others. May help them understand how they're trending over time. Are we getting better? Are we getting worse? Did we have some time periods where we were extremely efficient, but now we're not as much? And can we go back and figure out what happened in those time periods where we were able to be more efficient? You know, what if we could get all of our departments to be the most efficient they've ever been, all in the same month? What would that change? And with that gets into some process improvement. So you can think lean. You know, I don't care if you call it lean or, you know, whatever else you look at for process improvement. At the end of the day, whatever that process is, it's looking at how do you rebuild. And sometimes it's as simple as thinking about taking the apple cart and dumping it, putting it back together. How do you rebuild your organization so you can get more throughput, more efficiently, more satisfaction for the staff, more for the patients, by just looking at lean or whatever else you want to call that. Operational assessments, this is a little bit more resource intense, and to get into. This is actually where you're looking at benchmarks and processes and opportunities. A lot of times it's somebody external that comes in and says, okay, based on what's going on in your organization, what I've seen in others, where your opportunities are, you know, this is really digging into saying, how do you make some big changes? Sometimes I almost like operational assessments before lean, because I think operational assessments sometimes can find low-hanging fruit. And when you get those large components of low-hanging fruit, the savings and the efficiencies you build there help you create the finances and the funding you need to push and promote the lean and the other things. Lean's great, but sometimes it doesn't always hit as big of a bang as you could if you're looking at some higher level operational assessments with some big dollars might be able to come into play quickly. So some opportunity there. Next, we talked about cost report preparation strategies. The cost report sometimes gets kind of thought of as just this regurgitation of the past. Basically reporting what happened in the past. But there's a lot of planning that can go into things. You have to be accurate as to reporting the past, but you can start looking at other options. It's kind of like your tax return. You can go in and work with your tax planner, and you guys can work on, handling different funds and different things in different ways so you get better tax treatment. There's the same kinds of things with expenses on the cost report. Sometimes you can make requests or make elections to get approval to do something a little differently. Or maybe if you change your organizational structure, who's reporting to who and things like that in your organization, those types of things might change where the costs get allocated. Lots of opportunity in that area. A lot of people will say they've done it once or they did it several years ago. This is something that probably should be done probably about every 3 years, regardless of where a facility is at, just because our organization changes. As the structure changes or something else changes, there's a lot of different things that you can look at doing differently. So not a one-time process. What I would say here is if an organization is going through the normal, moderate kinds of changes, maybe once every 3 years, a deep dive in the organization makes sense. Having said that, if the organization does a huge, significant change in a given year, I wouldn't care if they've already done it a year ago. I'd just be stepping back and re-looking and making sure I got all the right elections, because it's those big changes that sometimes can give us some more opportunities if we're willing and able to dive deep and look at that piece. So these cost report preparation type things are the strategies. For a lot of times it's somebody just reviewing the cost report. It might be somebody who isn't the preparer. It's a different set of eyes. A lot of times these cost reports are settling tens of millions of dollars worth of costs. Sometimes it makes sense to have somebody who wasn't the preparer to look at it and say, hey, is there a different way to do things? There's some other things that you might want to consider, things like that. Again, don't have to do it every year, but definitely on a periodic basis, you want to do that. It's also really important to make sure that the staff understand the importance of the info that they're giving the preparer, because the preparer can only do as well as the information that's been provided to them. New programming option. I just want to pop this out here. I know we're hearing a little about this here. Or in some states a lot. Rural Emergency Hospital Program, a new opportunity in 2023. Unfortunately, the process of being able to get licensed and everything is taking longer than the timing is, as far as when the government says that they'll be ready. From the federal level, January 1st, 2023, facilities could license up as a rural emergency hospital. Problem is that it's not ready in all the states, not in many states. Some have passed laws so you could license, but the intricacies of how you're going to license haven't all been figured out yet. At the same time, even if you do that there, some of the Medicaid programs, or probably all of them now that so far from what I've looked at, they haven't determined how they're going to pay an REH, so they got to figure out how that's going to work. We don't know how commercial payers are going to handle it. But having said that, it's definitely going to be a lifesaver for some organizations. And so I am getting a lot more calls about looking at this program. It's a little different than a regular hospital, no inpatient services. If you're going to do swing bed, it's got to be in a nursing home setting. You basically get OPPS payments plus 5% plus fee schedule payment. And that is a big reduction from cost. I'm just in the process now of completing one of my first large comprehensive analysis of an entity, and it's not going to be a benefit for this entity. I didn't think it was going to be, but their leadership thought it would possibly be. There's a lot of dollars and cents here, getting a lot of calls. They do get an extra supplemental payment. It's about 3.2 million. That's been the big carrot out there. Initially thought it'd be 2.5 million. So with the proposal now at 3.2, definitely getting a lot more people looking to do that. So if you have providers that are struggling, a lot of them are going to try to push back on it because they want to keep their inpatient, things like that. But for some facilities, this is going to be their option of the future, and definitely something that they should be talking to someone who understands the program, not just the impact it'll have for their entity today, but what the opportunities that might provide in the future, as well as what it might limit as opportunities in the future too. Because that's one of the things I've been watching, is that some folks aren't looking at how it limits things in the future that a facility needs to really consider, like new plant and things like that, though you're not going to get any cost-based reimbursement. So want everybody just to really keep this one in mind. And, again, if somebody's got a potential need, get them in touch with somebody that can help them look at what the operational and financial pieces are. I get probably about 10 of them now that we're looking at real seriously. A couple of them are going to be slam dunks. They're going to be easy ones that we know are absolutely going to work. Some of them are looking for a savior of something that we don't think the program is going to provide that, but it's definitely something that some are going to want to look at. So the most important step of all of this, when we're talking about all the challenges and everything else, is timing is of the essence. And what I mean by that is I've had 2 calls in the last week or so, a couple weeks, maybe a little longer than that, of entities that are basically what I would call hemorrhaging. And they need to find solutions, and they need to find solutions fast. One of the organizations I'm working with, I don't know if we can save them. And the reason that we can't save them is because we didn't get pulled in early enough, when they still had dollars and cents in finances to help make some change happen and weather a little bit of the storm yet as they were improving. Those cash reserves are gone, and they may not be able to get to the next level of where they need to be before the cash and everything else runs out. So they're going to have problems with, staff, supplies, everything. Once you lose those cash reserves in today's environment, it's almost impossible to get it back. So it's really important to be jumping on that. I always tell people, when you're hurting and struggling financially versus hemorrhaging, it's a lot easier to make plans. When you just got the pains and things like that, you have more time to make changes. You can try more different types of things, all of that. Again, I've just seen too many providers that are waiting until they're too backed up into a corner. One of them I talked to basically had maybe 6 months cash at the burn rate they have. And so 6 months is not a lot of time to totally reconfigure and run an organization. I got some options and things that we're working on, we may be able to figure it out. But those are the types of challenges. We don't want people to get in that deep. You don't want them to be in that deep. So whoever they're working with, they need to be looking for help or doing things in themselves. They can do it themselves, but they definitely need to get the process moving earlier than later. And it is a lot more critical than what I would say we've seen for a lot of years. So with that, I'd like to open it up to some questions, see what kind of questions people might have for me, and see if there's things that we can kind of give you some guidance as to some things you may want to look at.
Feel free to come up or
go ahead.
put your questions in the comment box, and we'll take a look at it. Either or. Sorry. Okay.
Yep. I see. So, do you anticipate REHs being included for 340B? 340B is unless we get a legislative, congressional changes in the law, no. That's the importance of advocacy and getting out there and getting people to change that. As far as FlexShip and the others, I think I would turn that maybe more over to the center to see what they know there. The health services core, I think we'll see some eligibility there. I just haven't seen any specifics on that.
Great.
How many months cash reserves should they have? You know, I always like to see them probably in that 180 days of cash availability. Now that's assuming they're not burning cash. Because if you have, you know, if you have 180 days in there, but you're not generating cash, and next month you've got 160, and the next month you got 120, the writing's all of a sudden on the wall. And those are the things that we're watching, is that when you look at like the flex monitoring trend and, you know, using their calculations, we saw a huge increase in the days cash that people had through COVID because we got all this extra money. So that kind of gave us a false sense of security as a facility. And if we were looking at data, you know, we all know data can tell us good things, but it also kind of lie or give us some false impressions. They would have looked really healthy from a cash perspective if you didn't know that that cash had a home that was going to have to be spent on. And when it was gone, there wasn't going to be a replenishment of it. And that's what we're seeing now, is all of a sudden these days cash are dropping fast. So it's the trend probably as important as the number of months they have. Look at it over 6 to 12 months.
Ralph, can you, and maybe Terry can chime in on this as well, explain, you know, this is a lot of good stuff, and you presented a lot of interventions, like, hey, if this is happening, then maybe this is the direction to go to. Can you maybe speak a little bit to how important it is to get board leadership and other varying people, not just the CEO, but other people and entities within the organization on board with the strategic planning and looking ahead?
Absolutely. Thank you for that's a great lead in. It's a perfect lead in.
Perfect.
So Terry and I actually had the opportunity to spend a better part of a week together a couple months ago, traveling the state and actually working with trustees. And people do not give trustees enough information, and it's hard to get them information because they're volunteers, and it's hard to get them to go to, you know, take a weekend and things like that. But we were able to hit 3 spots in a state and really meet with trustees and provide them this kind of information. Obviously, we dove a lot deeper. Terry had some pieces that he talked in depth about population health and some workforce and some other components. And I will tell you, they ate it up. But they need, because we were giving them pieces of information that they didn't have. And sometimes boards don't know what to do because no one's given them the information. So anytime you can get this kind of information, or preferably more in depth, our days were like 5.5 hours or something like that of time with these individuals. They need that kind of level. Once they get that, they are now in a much better position to understand the challenges as well as what are the opportunities. Sometimes they don't even know where to start. And I hope and I believe through what, you know, Terry and I did together traveling that state, that there were providers that walked away with a better understanding of what's going on, how to prepare for the future, and what kind of questions and things to ask. So I would ask Terry to, you know, for any additional comment that he might have on that. I thought it was a great process.
Yeah, I don't know how much more I can add to that, Ralph. And I really like the focus on the board members, you know, because so often they get left behind, or they're not understanding the changes that are happening as well. So it was kind of an intense week, but I really enjoyed it.
Yeah, thanks for sharing on that. We also have several different leadership series videos available at the center as well. Sometimes I wonder, and I work for TASC, I work for the center, but sometimes I wonder, like, how can a flex coordinator or flex director, manager take this information, what role do they play in this, besides just answering some questions, or how can they be more proactive in this financial conversation with hospitals?
Well, I think if you can make sure that everyone knows about that's available, I think that's a starting spot. But then giving them ideas of how to introduce it to the board, and then making it part of what they do. I've got some entities that use a little bit of material from different sources at a board meeting. Now, in a board meeting, what they're trying to do is do something that's shorter. So maybe it's 20 minutes, maybe a little more, a little less, but trying to keep it something short and concise, but using it at the board meeting. So that could be a video. It could be a presentation, a live presentation, if you engage somebody to do something like that. But I think that's the best way to start trying to get more board members engaged, because I don't see the traction I would like to see when people put together a trustee retreat in the state and it takes a weekend. There's the travel, and it's usually done in one spot, so everybody's got to travel from from wherever they are to that spot. When Terry and I did ours, the fun part about that one was that it was in 3 different spots, so it was not as much travel, but it didn't take the weekend away from these volunteers and things like that. I think you just have a better shot at getting some engagement.
Yeah, I think that's good advice there, Ralph. And I think for flex state workers, I think part of your job it's not always going to be the technical aspect, but also sometimes just being a cheerleader, right? Just being there to say, have you considered this? Have you done that? And just having some of this information and the references and the ability to point hospitals in the right direction. So one thing I often say is, like, you don't have to be the expert in this. We have people like Ralph that are the expert in this. But it's good to know that this is information. You got to have something in your toolbox to provide them, especially if a hospital is struggling and they're not, as Ralph said, he had those 2 entities that were both waited a little bit too long to reach out to get the right help. So if you have a hospital in your state that's waiting too long, these should provide you some tools to be able to sit there and go to them and say, hey, you need to be reaching out. You need to be taking advantage of this. So I would encourage everybody. Does anybody else have any questions? I know we put some leadership chat post in the chat, and we have the Finance 101 manual that's updated annually in the chat as well. But does anybody else have any questions for Ralph? I know he's got another thing to go off and save the world in another place. And so we'll give this opportunity if anybody else has anything.
Well, by all means, you got my contact information. If you have any questions, just make sure you reach out and we'll see if we can help find resources.
Well, we really appreciate you, Ralph. As always, thank you for your time, your efforts, and thank you for giving us some tools that we can use out here in our states. We appreciate it.
All right. You guys have a great rest of the day.
Thank you.
Bye-bye.
All right, so at this time, we do want to do program updates. These are important updates for you. I am going to randomly call on someone. Actually, I'm not. We're going to start with the federal updates. I do believe Laura is here and will provide some updates and some information. Super important because I do believe we have a lot of deadlines coming up. Laura?
You are right. We do have a lot of deadlines. So I'll just give everybody a quick rundown of what we have coming up. And if you have any questions, please do not hesitate to reach out to me or to your project officer. You have seen lots of emails about this. There will be a lot more email reminders, so don't panic. And if you don't write it down right now, the most urgent deadline that we have is next week. Your PIMS reports are due next week. I would highly recommend, even though they are due, the due date registered in EHB is the 29th. That is a Saturday. The last business day to be able to complete your PIMS report is on Friday, the 28th. I would recommend not waiting until the last moment, because we know sometimes, I think every one of us has tried to mess with EHB and had things not work the way it was supposed to. So just try to jump in there early if you can, especially if you need to access your prior PIMS reports. I have been hearing from a lot of states that EHB is not able to access them, and I'm not either. I've tried. you have to ask for help from the EHB help desk. So that will take a couple of days for them to get them to you. So please jump in there now. If you have any questions, don't hesitate to reach out to us. We're here to help you. And then following that, your deadlines in November are all on the same day, November 30th, and it will be your end of year report along with the final quality improvement lab evaluation spreadsheet, all submitted in one task in EHB. And then the request for information that we sent to all of you for the budget breakdown for how you plan to spend your rural emergency hospital funding. Christy and I are working on some more resources for all of you, possibly another webinar, hopefully coming up to talk a little bit more about REH stuff. We know that that is still an ongoing question. We don't have a lot of the answers yet, but we're still working on more stuff to get out to everybody. So those are my updates for right now. We're getting into the closeout of the year. So hopefully all of you are starting to think about what may happen with your any unobligated balances you might have, any carryover requests that you might be doing. So start reaching out to your project officers right now if you want to have those conversations. And Liz, I see your question. What is it that we need to request from EHB? Yes, Caroline's right. It's the prior PIMS reports. If you want to access them, there's usually a link on the left-hand side of the PIMS screen where you can just click on them and download the PDF reports from previous years of PIMS. But for some reason, EHB can't, they won't load. It just circles for a while and then says there's no access. So if you need those and you do not already have them saved from someone who may have saved them previously, you'll have to ask for the EHB help desk to send you those prior PDFs.
Great. Any questions for Laura? We know we answered Liz's question. I'm going to jump on a little bit of a soapbox here and say this is a good opportunity in the back of your head to be thinking about program continuity as well, and making sure that you're saving your resources, your data points, things like that in a easily accessible place for other people on your team or people that will follow you or join your team in the future. It will be good to have that organized and accessible for future evaluations and future reporting. We got a question. Let's see here. Have we published templates for the REH work?
No, we do not have those published yet. That is still forthcoming. And I also want to shout out Caleb for the PIMS data collection tool. That is a great tool, like you just said, Matt, to save all of your data on your own computers.
Yes.
But to Laura Fisher's point, we are still working on exactly what we need for all of that. There's a lot of things that still change day to day on all of it on our end. So we are working on it. Stay tuned for and watch your emails.
Fantastic. If you have any more questions, feel free to put them in the chat. We'll get to them. Thank you, Laura. And I am going to call on Janelle, who is going to give us an update for Stratus and Arquita.
Hi, everybody. So I have 4 updates for you today. The first is Arquita will be reaching out to you soon, like maybe later this week or early next week from Sarah about scheduling one-to-one calls with all 45 state flex programs. So we'll be doing those calls over the next few months. The purpose of them are to learn about your work, what you're doing to support quality reporting and improvement in your state, to identify opportunities to spotlight and learn from your work with critical access hospitals in this area, and then to gather feedback from you about how we can better support your work. So look for that email from Sarah soon. I guess it is early next week. And then the second thing is an updated antibiotic stewardship resource. So the antibiotic stewardship detailed data summarization tool has been updated to align with the 2021 annual facility survey. So this tool allows the state flex programs to summarize and make use of the core and detailed annual facility survey antibiotic stewardship data. And thanks to Nicole, it's posted just today. So I'll put the link in chat for you if you'd like to go and look at it. Thirdly, there is just a reminder about the round 2 QI project office hours, which is in December. And so this is with the federal partners. And just for those of you that have been on the other ones, just know that there's no prepared content, but rather it's an opportunity for you to join with your questions and hear answers from your peers as you're wrapping up your QI projects and planning for related deliverables. So the dates of those are December 1st, and it's 1 to 2 Eastern, or the 8th, 4 to 5 Eastern, and you can participate in any, all, or none, whatever you choose. And then the last thing is just a reminder about the BKG in December. It's the 15th at 2 p.m. Central Time.
Perfect. Janelle, regarding the Sarah email that's going to come out and the one-on-one calls, is there anything that the states need to be prepared to share specifically, like their contact, like if they have contractors or things like that, that they need to make sure that they have their updated information?
Yeah, she will be sending it to the Flex staff, but you are free to invite whoever you think is most appropriate. So I just reviewed the email Sarah sending out today, and I think it's pretty self-explanatory. There's no prep for the call. You're just really sharing your story and telling us,
Okay.
what's going on in your state. But that's thanks, Matt, for asking that question.
Yeah, I think that's always kind of a question, like, what do I need to prepare for? So that was
no homework.
great. And then I am going to call on Megan from FMT. We really appreciate you, Janelle. And while she speaks, I'm going to have Patricia launch the polling. I know some of you guys got to head out, so we want to capture those. As you all know, data is important. So please take the time to do that polling. And Megan, you're up.
Great, thanks, Matt. Just a few updates from the Flex monitoring team. Excuse me. In the next couple of weeks, we expect to release a couple of new products. One will be on financial characteristics of CAHs participating in accountable care organizations. And the other will be on delivery of cancer screening and treatment in CAHs. And so both of those, if you're not already on our Flex or on our FMT DIS list, sign up on our website, and those will be coming out in the next couple of weeks. Additionally, within the next month or so, we're going to have several updates for the MBQIP reports. We'll have 2 sets of quarterly reports coming out in November. That's both the EDTC reports and the patient safety inpatient and outpatient reports. And also in the month of November, we are aiming to release our annual MBQIP reports. And so those, all of those hopefully out by the end of November. We'll also have some upcoming products coming out on projects that we've worked on related to interpretation services in CAHs and the impact of CAH system affiliation during COVID. And still working on our projects for this year on all sorts of things. And so you might hear from us on some of these, but looking at outcome measures in population health and EMS program areas, the financial impact of COVID on CAHs, so very relevant to today's discussion, looking at advanced electronic health record use in CAHs, CAH emergency preparedness planning, and a final evaluation of the QI project in collaboration with TASC and ARKITA, like Laura mentioned. Those evaluation materials due at the end of November. And that's about it. If there's any questions on anyone, I'm happy to answer them, but always feel free to reach out to our team with questions on any of our products or MBQIP reports or anything else.
Thank you, Megan. We appreciate you and your hard work up there. And speaking of hard work up there in the great state of Minnesota, the Flex workshop is next week. This is our first one that will be in person since the pandemic. We are very excited to welcome a bunch of people to Duluth, Minnesota, where it is the frozen tundra. I'm just kidding. It's not tundra like yet up there. It'll be a great week. And so wish us luck. We'll be posting some updates about that. As Laura said, PIMS reporting technically due on October 29th, but 28th is the last business day. So please make sure you take the time to try to get it in early, just in case there's any problems. We also want to, obviously, many of you know this, if you work with SHIP, the applications, NOFO applications for FY23 through 28 are due on November 8th. And in response to that, we are having an office hours call. The SHIP TA team at the center is having an office hours call next Thursday, October 27th in the afternoon, to just answer any last minute questions that you might have. It is getting close to the time where we won't have much time to answer questions where you can make changes to your narrative or your reports. So get those in, feel free to ask them. We're answering a ton of them every day. We want to be as much help as possible to you. The November 15th VKG is coming up, and I don't know why I put that one before the SHIP webinar, but the SHIP webinar is the day before, Monday the 14th. We understand that's a Monday. We tried hard not to put it on a Monday, but with the Veterans Day and Thanksgiving holiday, things are kind of getting wonky there. That's also National Rural Health Week. Rural Health Day is that Thursday, I do believe. And so also, we have made the determination that the RSV next summer will be in person in Washington, D.C. That will be July 19th through 20th. More formal announcements coming later, things of that nature, theming, yada, yada, but it will be in person. It will be in DC, and we will be sending out an email shortly about the RSV committee. And so if you are interested in doing that and have not done that in the past, or have done it in the past and are now like, yay, we're in person, I want to be a part of that again, we'd love to have you. So keep that in mind. And certainly not the least important, but the most profound, is we have updated the core competencies for state flex program excellency. And they are going to be published here shortly. So be on the lookout for an email from TASC outlining what the new changes are, what you can do, how you can use it. We know those can be overwhelming sometimes, but we really want you and hope that this new approach to it is very molecular, in that you can do one thing individually, but they all come together. So not to be overwhelming and you have to be an expert in all of them, but more so of, hey, take one of these, and if you can be good in this, then you'll be good in all of these type of situations. So we are very excited about that. I would like to open it up and see if there are any questions about those updates, or if anybody else here has anything else to chime in on about. Yes, RSV in person. Absolutely. Very excited about the RSV in person. I have nothing else to say. I've never done an RSV in person. So it will have been 4 years since the last in-person RSV when we do next summer's. So that's a very exciting time. So any other questions, comments, dedications, complaints, concerns, anything of the sort? We are definitely early today, probably because we switched up the schedule a little bit. So we want to give this opportunity to you and see if you have any comments or concerns. I keep saying concerns. We want to hear your concerns, but if you have a comment over a concern, we would like to hear those as well. It is nice to have known that I have met some of you in person at NOSORA. That was a good time. Thank you for reaching out and shaking my hand and saying hi. I appreciate that. All right. Well, if there is nothing else, we appreciate you guys. We hope you have a fantastic week. We know you guys have a lot of reports and writing to do, so let's get back to it. Remember that what you're doing and all of that is helping other people get better healthcare. Sometimes you may not ever meet them or know them, but you are making a difference. I see Caleb came off of mute. Caleb?
Really just say thanks, guys. Thanks for coming to the TASC 90. We'll see a few of you guys next week in Duluth, but yeah, thanks, guys.
I appreciate you guys. Have a good afternoon.
Have a good day.